So you know about the fungus. So fungus is a bit different from the bacteria or protozoa. So they have different types of the cell wall composition, different types of the cell membrane composition. For example, in the cell wall, they mainly contains the chitin instead of the peptidoglycans, which is the main component of bacteria. Similarly, in the cell membrane of the fungus, there is ergosterol in comparison to the presence of the cholesterol in mammalian cells, our cells. So in the cell wall, they contains chitin, in the cell membrane, they contains ergosterol. They are eukaryotic cells and they are different than the other bacteria or protozoa. That's why the different other antimicrobial agents, other antibacterial drugs are not effective against the fungus and vis-a-vis. That is, the antifungal drugs are also not effective against the different types of the bacteria. So this fungus, ultimately they may cause different types of the diseases. What happens recently with different types of the immunosuppressive disease, increase of the immunosuppressive disease. For example, there are organ transplant that is becoming quite common. There may be HIV AIDS, there may be cancer chemotherapy induced neutropenia. So these are the areas where the immunity system of us are quite compromised. And in those cases, there are more chances of opportunistic fungus infection. So there is more chances of the opportunistic fungus infection, and on the other hand, there are different types of the superficial mycotic infections. For example, there may be some different types of the tinea infection, tinea solium, tinea infection, like there may be tinea capitis, tinea versicolor, etc. And if the fungus becomes very much high, concentration in the blood, the fungus infection, that ultimately leads to different types of the invasive fungus infection. And for this also we need different types of the antifungal drugs. Opportunistic infections, so you can see this is the superficial infections, quite common, skin, hair, nails, mucous membrane, and in the deep there may be tissue invasion of the tissues like muscle and connective tissue, organs, all this can happen. So superficial mycosis, that mainly affect the skin, hair and nails. Subcutaneous mycosis, somewhat differ. Systemic or invasive mycosis, very dangerous. And allergic mycosis, due to some allergy, may happen. So this invasive mycotic infections most commonly happens due to some immunocompromised patients. In spite of invention of different antifungal drugs, the mortality rate is quite high. You can see the mortality is approximately 50% to 70% if the fungus infection becomes invasive. So that's the problem. So this is the most common fungal infection, like dermatophytes, like Microsporum epidermophyton trichophyton. This causes different types of the tinea infections. Candida, quite common, Candida albicans, glabrata tropicalis. So Candida may cause superficial as well as deep infections. Aspergillus, quite common, Cryptococcus, Rhizopas. These are the common infections. Apart from this, there are variety of the fungal infections are there. The superficial infections are mostly caused by dermatophytes or ringworm like Tinea pedis, Tinea cruris, Tinea capitis. Candida may cause oral thrush may happen, may be caused by Candida vaginitis, candidiasis. If the Candida becomes more prevalent in the blood, this is known as candidemia. All this can happen. Candidiasis, aspergillosis, coccidioidomycosis, histoplasmosis, this can cause deep infections, that is different organs may be affected. So these are the site of actions of different antifungal drugs. So already we have seen that there are different types of the cell wall, cell membrane, nucleus, etc. So different drugs, the target are the different. For example, the membrane function can be targeted most commonly by Amphotericin B. Ergosterol synthesis, which is an important part of the cell membrane of the fungus, can be targeted by different types of the azole antifungals like Fluconazole, Itraconazole, Voriconazole. Apart from this, Naptifine and another antifungal like Terbinafine. Nucleic acid synthesis can be blocked by 5-fluorocytosine, and cell wall synthesis can be blocked by different types of the Echinocandins. Within this, Caspofungin, Micafungin, etc. are there. So this is the classifications. For example, inhibitor of the cell wall synthesis. This can be done by Echinocandins. Example is Caspofungin. drugs that alter the membrane permeability, that is the cell membrane of the fungus permeability is changed. It is caused by the amphotericin B, nystatin, hamycin. So this mainly acts on the cell membrane of the fungus, inhibits nucleic acid synthesis, 5-Flucytosine, disruption of the mitotic spindle. This is done by the Griseofulvin. Drugs altering membrane synthesis. This can be either inhibition of the ergosterol. There are two types of the antifungal drugs are there, Imidazoles and Triazoles. Example of the Imidazoles are the Ketoconazole, Miconazole, Clotrimazole, and the examples of the Triazoles are Fluconazole, Itraconazole, Voriconazole. Very commonly used these are. And inhibition of the both ergosterol as well as the lanosterol, which is a byproduct of the ergosterol and in the pathway of the ergosterol synthesis. This is done by the newer drugs, Terbinafine, very commonly used nowadays. So this is more or less about the different antifungal drugs. So you have to know that what antifungal drugs acts on what areas. That is, some drugs act on cell wall, some drugs act on the cell membrane, some drugs act on the nucleus. So first, coming to the cell membrane active antifungals. These are very effective antifungal drugs, of which the Amphotericin B is the precursor drug, the main drug, and this was the first invented antifungal drug, Amphotericin B. So this comes under chemical group known as the polyenes. So these are known as the polyene antibiotics. Polyene antibiotics, example Amphotericin B. And there are different formulations of the Amphotericin B as there. We will discuss about this. Nystatin that can be used topically. Apart from this, another group of drugs that also acts on the cell membrane are the azole antifungals. Already we have seen azole antifungals. This one, drugs that alter the membrane synthesis. These are the membrane synthesis altering azole antifungals. And this Amphotericin B nystatin mainly alters the membrane permeability. That is, both of these two groups acts on the cell membrane but in somewhat different ways. So imidazoles and triazoles, already we know about the names, that there are two groups of the azole antifungals. One is the imidazole group, another is the triazole group. So first, coming to the Amphotericin B. Amphotericin B is basically a fermentation product of Streptomyces nodosas. So Streptomyces nodosas is available in the environment, and from which this Amphotericin B can be synthesized. They have high affinity for ergosterol present in fungal cell membrane. So fungal cell membrane contains the ergosterol and they have high affinity towards this. They have, you can see this is the macrocyclic ring, that is there are different, this is a very large number of the rings are there, of which one part is the hydrophilic part, another part is the lipophilic part. So hydrophilic polyhydroxyl chain along one side and a lipophilic polyene hydrocarbon chain on the other side. So this is a highly double bonded structure. So this is the structure of the Amphotericin B. On one hand, on the one side there is hydrophilic side, and the another side there is lipophilic side. This lipophilic side is the polyene side. That's why they are known as the polyene antibiotics. What happens? This Amphotericin B, when it is given, it binds to sterols in fungal cell membrane. That is this ergosterol, and they have high affinity for ergosterol present in fungal cell membrane, and affinity is less for host cell membrane, although closely resembles. Our host cell, that is mammalian cell, contains the cholesterol as a part of the cell membrane. Ergosterol mimics cholesterol in the structure, but somewhat it is different. That's why Amphotericin B has high affinity for the fungal cells that contains ergosterol in their cell membrane rather than the host cell membrane. Nonetheless, host cells are also affected by Amphotericin B since they are ergosterol or cholesterol are similar. That's why this Amphotericin B, the conventional Amphotericin B, is very much toxic to the cells. What happens? Several polyene molecules, when they are given this polyene Amphotericin B, they orient themselves in such a way to form a micropore. So they orient and a micropore is formed, and this micropore is formed within the cell membrane, and that creates transmembrane channel and electrolyte leakage. When this micropore formation happens within the fungal cell membrane, mainly potassium and some other electrolytes are leaked out. So permeability is increased and leaking of the electrolytes that is necessary for the survival of the fungus are leaked out. They are active against most fungi except the Aspergillus and Scedosporium species. bacteria lacks sterol, so insensitive to polyenes. This amphotericin B, bacteria are insensitive, but amphotericin B is also active against the leishmaniasis. Okay, leishmania normally, kalaja. So mechanism of actions already we have seen. So amphotericin B, they orient themselves, the hydrophobic part attached with the ergosterol, and ultimately there will be micropore formation. Within this micropore, leaking of the potassium and other small molecules, different electrolytes happens. So the same thing, amphotericin B binds ergosterol in fungal cell membrane, form pores in cell membrane, hydrophilic site forms interior of the pore, and micropore is stabilized by membrane sterols which fill up the spaces between amphotericin B molecule on lipophilic site, cell contents leak out, and ultimately cell death happens. So this is the most toxic antifungal. Fungicide at high concentration and fungistatic at low concentration, and they are effective against the Candida albicans, Histoplasma capsulatum, Cryptococcus. They have limited activity against some protozoal leishmania, already I have said, and Naegleria fowleri. They have no antibacterial activity. This amphotericin B is insoluble in water, poorly absorbed from the gastrointestinal tract, but can be given orally for intestinal candidiasis, but mainly it is used as a intravenous dose, cannot cross the blood-brain barrier, highly bound to plasma proteins and sterols in tissues, takes approximately 2 months for complete clearance of the drug. So if it is given, ultimately it stores within the body, and that's why it is becoming more toxic. It is given as IV infusion, and for fungal meningitis it can be given even intrathecally. That is within the intrathecal administration of the amphotericin B can be done when there is fungal meningitis, when the meninges is involved. Penetration in CSF is poor, that's why intrathecal administration is needed. Has immunostimulant action, no dose adjustment needed in kidney or liver disease because it is toxic even in very low dose. Now some newer amphotericin B are prepared to decrease its toxicity. So they have decreased side effects, they have improved tolerability, they can get, this drug can be get to the site of action, they are less nephrotoxic and minimal anemia. This amphotericin B ultimately causes very much toxicity in the kidney. That's why the problem, nephrotoxicity, kidney toxicity is the main toxicity of the amphotericin B. These are the different newer formulations like amphotericin B lipid complex, amphotericin B colloidal dispersion, and liposomal amphotericin B. These are done in comparison to the conventional amphotericin B. Conventional amphotericin B mainly is a salt with the deoxycholate. So conventional amphotericin B is also known as the amphotericin B deoxycholate, but this amphotericin B, when it is given, it is very much toxic to the kidney, because in the kidney also they forms a micropore, they ultimately causes the tubule and glomerular damage, and ultimately the inside of the cells are leaked out, and there will be increased creatinine level, the creatinine clearance will be decreased. So this is the nephrotoxic potential of the amphotericin B conventional preparation or deoxycholate salt preparation. But when some lipid formulations, newer lipid formulations are coated, and within this the amphotericin B is supplied, this is known as the targeted drug delivery system. So ultimately when the target, the fungus is the target, fungus is present within some cells, within some organs, within which it usually goes and it forms the micropore, but in the kidney usually the micropore formation will not happen or will happen very minimally. That's why the toxicity is also less. But the problem is cost is also more. So these are the newer formulations, of which the most commonly used we are the liposomal amphotericin B, the liposomal formulations. So this is the conventional amphotericin B. It is insoluble in water but is formulated for IV infusion by complexing with the deoxycholate. Deoxycholate is a bile salt. So conventional amphotericin B, remember it is the amphotericin B deoxycholate. The complex is marketed as a lyophilized powder, and ultimately it forms a colloid in water. It has to be mixed particle largely less than 0.4 milliliter in diameter. It filters in intravenous infusion lines that trap particles greater than 0.22 millimeter. Will remove significant amounts of the drug. That's the problem. Since the molecule is very small, in intravenous infusions there will be filter and some drugs will also be removed. That is the problem. Addition of the electrolytes to infusion solution causes the colloid to aggregate. So electrolytes can be added when the conventional amphotericin B is given. This is known as the Amphotericin B colloidal dispersion. This is the newer lipid formulations. Contains roughly equimolar amounts of the Amphotericin B and cholesterol sulfate formulated for injection. So cholesterol sulfate, this is added so that there will be more targeted drug delivery. It forms a colloidal solution when dispersed in aqueous solution. It provides much lower blood levels than the conventional Amphotericin B. So that is the problem. So in a comparison of this Amphotericin B colloidal dispersion, also known as the ABCD, and CAMB, that is the conventional Amphotericin B, in invasive aspergillosis patients, it has been seen to be less nephrotoxic, but it may cause more fever and chills when it is given by intravenous infusion. Administration usually done over 3 to 4 hours, and pre-medication means some anti-allergic or steroids are to be given beforehand so that the fever and the chills from the intravenous infusion will be less. This is the liposomal Amphotericin B, the most commonly used, also known as the ambisome. It is the small unilamellar vesicle formulation of the Amphotericin B. When it is given by intravenous infusion, the blood levels are shown to be almost equivalent to the conventional ones. That is, high concentrations are achieved within the blood level in comparison to the conventional Amphotericin B. They can be given in higher doses also. Blood levels has been achieved that exceed those obtained with conventional Amphotericin B. For example, 1 milligram per ml is the highest concentration that can be given by the conventional Amphotericin B. If it can be increased, there will be more toxicity to the kidney. But this liposomal Amphotericin B can be given approximately 10 times than the conventional Amphotericin B with very minimal toxicity to the kidney. So when the high concentration is needed, particularly in case of the invasive fungal infections, we need very high concentrations of the antifungal drugs. So liposomal Amphotericin B is very much beneficial. It consists of the 10% Amphotericin B incorporated in uniform size 60 to 80 nanometer unilamellar liposomes made up of lecithin and other biodegradable phospholipids. So it is a liposomal formulations. So in the first chapter you have read about the different drug formulations to increase the targeted drug delivery, liposomal formulations. This is the prime example, the liposomal Amphotericin B, where some unilamellar vesicle-like structure are formed, very small, within which the Amphotericin B is packed, and it is made up of lecithin and other biodegradable phospholipids, and it produces milder acute reactions, lower nephrotoxicity, minimal anemia, delivers Amphotericin B particularly to reticuloendothelial cells in liver and spleen. And it is important in febrile neutropenic not responding to antibacterial, critically ill deep mycosis, and also it is used in Kala-Jar. So when there is invasive mycosis within the organs, we need very high concentration of the liposomal Amphotericin B. This is another formulations, Amphotericin B lipid complex, ABLC. So it is a complex of the Amphotericin B with lipids like phosphatidylcholine and phosphatidylglycerol. It is given in a dose of 5 mg per kg in 5% dextrose, infused intravenously over 2 hours. Blood levels, again it is much lower to the Amphotericin B ABLC, and then with the same dose of the conventional Amphotericin B, it is effective in a variety of the mycoses, exception cryptococcal meningitis. Mainly it is approved for the salvage therapy of the deep mycosis. So this is more or less similar to the liposomal Amphotericin B, but most commonly in all of the world we are using the liposomal Amphotericin B. Next we can use the ABLC Amphotericin B lipid complex and the ABCD, that is the Amphotericin B colloidal dispersion. Apart from this, this is the conventional Amphotericin B or Amphotericin B deoxycholate that was present for the long period of the time. So Amphotericin B is very important for your examination purpose also. So what happens? These three lipid formulations collectively appear to reduce the risk of the patient's serum creatinine doubling during therapy by 58%. That means when we are using the conventional Amphotericin B and when we are using the other lipid formulations, approximately half times of the patients will show increase of the creatinine level, that is showing that the kidney is affected. That is very less patients are suffering. In patients at high risk of the nephrotoxicity, ABLC is more nephrotoxic than liposomal Amphotericin B. That is, within these three lipid formulations, again liposomal Amphotericin B is minimal nephrotoxic in comparison to the other two, that is the amphotericin B colloidal dispersion and the amphotericin B lipid complex. Infusion related reactions are not consistently reduced with the use of the lipid preparations, and ABCD causes more infusion related reactions than conventional one. Already we have seen. So amphotericin B colloidal dispersion, ultimately they causes more acute reactions, fever, chills. This can happen with the amphotericin B colloidal dispersion. Infusion related reactions typically decrease with subsequent infusions. That is, always these infusion related problems in all of the drugs is very grave in the first infusion, and subsequently the gravity decreases. The cost of the lipid formulations of the amphotericin B greatly exceeds that of the conventional amphotericin B. Cost is the only restraint, that only problem. It is very much costly in comparison to the conventional ones. Therapeutic uses, amphotericin B is very broad spectrum antifungal drugs. It is useful for candida that causes oral, vaginal and cutaneous candidiasis. It can be used in Cryptococcus infection, histoplasma infection, Aspergillus infection, and also in the leishmaniasis. Amphotericin B, though is a antifungal drug, is a drug of choice for the leishmaniasis. Now coming to the therapeutic uses, the same thing. Candida esophagitis responds to much lower doses than deeply invasive mycosis. So the same thing already I have said, that if the fungal infection becomes invasive, deeply invasive, we need more concentrations of the drug. Otherwise, Candida esophagitis, that is superficial, we can use lesser dose. Intrathecal infusion, already we have seen, it can be used when there is meningitis caused by the coccidioides. Intrathecal administration of the amphotericin B. Conventional can be injected into the CSF of the lumbar spine, cisterna magna or lateral cerebral ventricle when the meninges will be affected. So this is also an example of the drug that can be given intrathecally. So if you are asked that give an example of intrathecal administration of drug, amphotericin B can be given intrathecally. Fever and headache are common reactions that may be decreased by intrathecal administration of 10 to 15 milligram of the hydrocortisone. Already we have said. So this is pre-medications. Pre-medications by steroids most commonly, or some anti-allergic drugs usually is given to decrease the infusion related problems. Local injections into a joint or peritoneal dialyzed fluid commonly produces irritation and pain. That is, it has also been done if there is fungal infections within the dialyzable fluid or within the some joint, within some joint fungal infection happens. Intraocular injection following pars plana vitrectomy has been used successfully for fungus endophthalmitis. That is, fungal infection occurs within the eye, endophthalmitis. Usually it happens if some eye surgery is done without sterilization of its instruments. So here we can use some intraocular injections of this antifungal drug like amphotericin B can also be done. IV administration is the treatment of choice for mucormycosis, is a very grave fungus infection. Initial treatment of the cryptococcal meningitis, or again it can be given. Severe or rapidly progressing histoplasmosis, blastomycosis, coccidioidomycosis and penicilliosis martinezii. Patients not responding to azole therapy of invasive aspergillosis, extracutaneous porotrichosis, fusariosis, alterniosis and trichosporosis. So usually the azole therapy is given, most commonly the aspergillosis is very commonly invasive, but if the patient will not respond to the azoles therapy, then we have to give in the amphotericin B. They can be given in selected patients with profound neutropenia. So neutropenia may happen if the patient are immunocompromised or if the patient is taking some cancer chemotherapy. So in those cases, there is more chances of the fungus infection. So we can give presumptively or prophylactically this amphotericin B. Adverse drug reactions, acute reactions, already we have said there are some infusion related acute reactions. Thrombophlebitis may happen, bone marrow depression, in some of the cases reversible anemia, intrathecal injections, headache, vomiting, nerve paralysis can happen. But the most important is the renal toxicity or nephrotoxicity that is characterized by the azotemia, decreased glomerular filtration rate, acidosis, hypokalemia, inability to concentrate urine. Nystatin is similar, more or less similar to the amphotericin B, but it is more toxic, used only for superficial candidiasis of skin, mouth, vagina, intestine and monilial vaginitis. For oral thrush, that is fungus infections in the oral cavity, the tablet of nystatin may be crushed and suspended in glycerin for application in the mouth, and it is ineffective in dermatophytosis. Dermatophytosis, it is usually not used. So this is also a polyene antimicrobial, polyene antifungal, more or less similar to the Amphotericin B. Other polyenes are the Hamycin and Natamycin. Hamycin is mainly used topically for Aspergillus candida, monilial vaginitis, Trichomonas vaginitis, etc. And Natamycin is mainly used in keratitis, monilial infection and Trichomonas vaginalis. That is more or less similar. Mainly it is used topically in the different types of the fungus infection, mostly in the vaginitis or different types of the candidiasis, etc. So Hamycin, Natamycin, Nystatin, these are the other examples of the polyene antifungals apart from the Amphotericin B. Next, coming to the azole antifungals. So azole antifungals, two main classes, imidazoles and triazoles, already we have seen. Imidazoles example, topically can be given clotrimazole, econazole, miconazole, and systemic can be given ketoconazole. Ketoconazole can be given topically also. Triazoles example is fluconazole, itraconazole, voriconazole, posaconazole, etc. Mainly ketoconazole is systemic, but these three, clotrimazole, econazole, miconazole, are always used topically. No systemic administration is there. So these azoles, so azole ring is there in all of this, and according to the different side chains, triazoles and imidazoles are differentiated. So the mechanism for actions of the azoles, this azole antifungal agents also acts on the cell membrane. Mainly the cytochrome P450 enzyme lanosterol 14 alpha demethylase. So they mainly binds to this and inhibits the production of the ergosterol. So this is the pathway by which ergosterol synthesis happens within the fungal cells, and this ergosterol forms the fungal cell membrane. So you can see from the acetyl-CoA, the squalene epoxidase, this is an important precursor. Here the terbinafine acts will come later, terbinafine blocks this, and this squalene epoxidase converts to lanosterol, lanosterol converts to different other intermediaries to ultimately form the ergosterol. See, this lanosterol to ergosterol formation is mainly blocked by the azole antifungal drugs. They mainly attaches with an enzyme, this is known as the P450 enzyme, that is, it is mainly mediated by the P450 cytochrome systems, lanosterol 14 alpha demethylase. So lanosterol 14 alpha demethylase, azole antifungals, both imidazoles and triazoles, they attach with the lanosterol 14 alpha demethylase. This enzyme is necessary for the conversion of the lanosterol to 4-demethyl cholesterol trienol, which is a precursor for in the synthesis of the ergosterol. After binding, ultimately they causes the blockade, so ergosterol synthesis will not happen. So some cross reactivity always happens with this because they are mainly mediated by the P450 enzyme systems, and there are different drugs that can inhibit or induce the P450 systems. So there are very much drug interactions with different types of the azole antifungal drugs. So you can see when the azole antifungals are given, there are more buddings of the fungus, that is increase of the number of the fungus that are drastically reduced when the azole antifungals are given. This is the Candida albicans. So ketoconazole is the first and prototype of the azole antifungal drugs. This is orally effective, useful in both dermatophytosis and deep mycosis. They are, the spectrum includes both the yeast and molds also. Poor absorption, that's why it is mainly used in the dermatophytosis. Pharmacokinetic is variable oral absorption dependent mainly on the pH, often given with fruit juice. Half-life is 7 to 10 hours, protein binding very high, greater than 99%, hepatic bile and kidney elimination happens. It is much less toxic than the Amphotericin B, but more side effects occur than with itraconazole or fluconazole, that is the other antifungal agents. Ketoconazole is toxic, more toxic than other azole antifungals, but less toxic than the Amphotericin B. Nausea and vomiting may happen with higher doses. Hepatotoxicity, increase in transaminase and hepatitis. Ketoconazole, the main adverse effect is the hepatotoxicity. Amphotericin B, main adverse effect is the nephrotoxicity. Dose-related inhibition of the cytochrome P450 system. So ketoconazole is an example of cytochrome P450 inhibitor. So it is an example of, for example, an example of the cytochrome P450 inducer, rifampicin. Cytochrome P450 inhibitor, ketoconazole, very common. Okay. So dose related, this is also responsible for testosterone synthesis, this P450 enzyme. That's why testosterone synthesis is also blocked when the ketoconazole is given in high dose for a long period of time. So there may be gynecomastia, oligospermia, decreased libido, all this can happen with ketoconazole. Also adrenal cortisol synthesis also decreased, and Addison's disease can also happen with ketoconazole, because all these depends upon the P450 enzyme systems, and ketoconazole is a potent inhibitor of the P450 system. That's why these problems happen. Drug interactions, drug interactions happens. For example, rifampicin and phenytoin, they are drug inducer, they decrease ketoconazole level. Ketoconazole on the other hand increases the cyclosporin, warfarin, corticosteroid, theophylline levels. For example, warfarin, when I have taken classes on the warfarin, I have also said that warfarin there are numerous drug-drug interactions, and warfarin needs intense monitoring, otherwise there will be bleeding or there will be subtherapeutic effect, because it is an anticoagulant, oral anticoagulant. So this is ketoconazole, warfarin, this interaction is very common, that is the problem. Drugs that increase the gastric pH will decrease the blood levels of the ketoconazole. So gastric pH increase, that is if there is alkalosis, that decreases the absorption. For example, when we are using antacid or proton pump inhibitor or H2 blocker, that is if there is dyspepsia, we are taking some proton pump inhibitor and also ketoconazole is taken. Ultimately, that decrease the blood levels of the ketoconazole, that is subtherapeutic effect. The effect will not happen of the ketoconazole, that may also happen. For serious infections, usually 800 mg per day orally is given. In the less serious infection, 200 to 400 mg per day is given. Apart from this, ketoconazole ointment is lesser used, but shampoo is available that can be used in the tinea capitis. Fluconazole, it is a water soluble having wide range of activity than ketoconazole, good activity against the Candida albicans and Cryptococcus neoformans. You can see the problem is the fluconazole is many fungus become resistant to the fluconazole. For example, this Candida krusei becomes totally resistant to the fluconazole, Candida glabrata somewhat, and sometimes resistance in different other Candida species. For example, Candida tropicalis, parapylosis and kefir. So resistance with the fluconazole is the problem. Both primary resistance and secondary resistance are associated with the fluconazole. Primary means from the first the fungus already become resistant to the fluconazole, and secondary means if the patient is continuing using the fluconazole, the patient becomes resistant to the fluconazole. All this can happen. Fluconazole, the dose 200 mg on the first day and then 100 mg daily for at least 2 weeks is effective in oropharyngeal candidiasis. Oropharyngeal candidiasis is quite common if the hygiene is not maintained. For example, if the patient is taking for some inhaled corticosteroids, example, so there are different types of the inhaled corticosteroid and combinations of the beta agonist also. So when these patients are taken this, there is always chances of the candidiasis. That's why the patients are usually asked to do some mouth washing after taking the inhaler. So if there is deposits of the different drugs of the corticosteroids for the long period of time in the mouth, there will be oropharyngeal candidiasis. This is one example. So single dose of the 150 mg effective in uncomplicated vaginal candidiasis. This is also common. Vaginal candidiasis uncomplicated, usually single dose 150 mg is given. A dose of 400 mg daily decreases the incidence of the deep candidiasis in allogenic bone marrow transplant. Already I have said that with organ transplant, with bone marrow transplant, the patients become immunocompromised and there is more chances of the opportunistic fungus infections. Fluconazole 400 mg daily for the initial 8 weeks is usually given in cryptococcal meningitis with AIDS patients after they have been stabilized with the Amphotericin B. So Amphotericin B, since it is very much toxic, even if the liposomal it is given, even with less toxicity, the kidney will be affected somewhat. That's why it is not given for a long period of time. So after being stable, the patients are usually switched to some other antifungal drugs, most commonly different types of the azole antifungals like fluconazole. Drug of choice for the coccidiodal meningitis, also it is given for the coccidiodal meningitis. Itraconazole. Itraconazole is another azole antifungal. It is an equimolar receiving mixture of the 4 diastereoisomers. So this is medically mixture of the isomers metabolized in the liver. Again, it is a potent inhibitor of the cytochrome 3A4. They are very highly bound to proteins. They neither appears in the urine or CSF. The half-life is approximately 30 to 40 hours, very high. broader spectrum than the ketoconazole and the fluconazole. It includes molds like Aspergillus and they have fungistatic action. This is the drug of choice with indolent non-meningeal infection like Bordetella dermatitis, Histoplasma capsulatum, Brasiliensis, Imitis, etc. The drug is also useful in the therapy of indolent invasive aspergillosis outside the CNS. So, invasive aspergillosis, it can be used. HIV infected patients with disseminated histoplasmosis or Penicillium marneae infections, we can use this itraconazole. So, itraconazole is mainly used in invasive aspergillosis, indolent non-meningeal infections of different fungus drugs, disseminated histoplasmosis, Penicillium marneae infections, etc. Long-term therapy has been used in non-HIV infected patients with allergic bronchopulmonary aspergillosis. This is also a serious condition, allergic bronchopulmonary aspergillosis. Here we can use the itraconazole for a long period of time. It is effective and approved for use in oropharyngeal and esophageal candidiasis. In both of the cases, either oropharyngeal candidiasis or esophageal candidiasis. Steroid hormone synthesis inhibition is absent and no serious hepatotoxicity. So this is contrast to the first one. You can see this ketoconazole. The most important problems with the ketoconazole is it is very much hepatotoxic. Next is they interfere with the adrenal cortisol synthesis. So there may be chances of the Addisonian disease. So these two are very less with the itraconazole and also fluconazole also. But the problem of the fluconazole is the resistance. Already you have said. Adverse drug reactions more or less similar. Interaction somewhere is there. It should not be given in congestive cardiac failure patients because they have some dose dependent inotropic effect. Hypokalemia may happen. That is the problem with the itraconazole. That is the potassium level may be decreased. Mainly who are taking high dose of the itraconazole 600 mg daily and also receive prolonged amphotericin B therapy, because amphotericin B therapy is also causing the hypokalemia, if you can remember. So amphotericin B plus itraconazole can cause a serious profound hypokalemia. Voriconazole, this is the newer ones, newer triazole with a structure similar to fluconazole but with an expanded spectrum, poor aqueous solubility, completely absorbed. Again it is metabolized by the cytochrome systems, metabolized excreted in urine, exhibits non-linear metabolism, so higher doses cause greater than linear increase in systemic drug exposure. That is, voriconazole may cause again toxicity if somewhat increase in dose of the happens because it causes non-linear metabolism. That's why for the voriconazole usually the therapeutic drug monitoring is needed if it is to be given for a long period of the time. It provides superior efficiency to conventional amphotericin B in the primary therapy of the invasive aspergillosis. So for invasive aspergillosis, we can use the intravenous administration of the voriconazole. It can be used in neutropenic patients where the fever did not respond to greater than 96 hours of the antibacterial therapy. Neutropenia, neutrophil count is very less, so there are different types of the infections are setting in. So there will be continuous fever. We are using the different antimicrobial, antibacterial agents, but the fever is not decreasing. Then we have to use the antifungal drugs like voriconazole. It is also approved for use in esophageal candidiasis, initial treatment of the candidemia, that is serious infections with candidias, invasive aspergillosis, as well as salvage therapy in patients with P. boydii and fusarium infections. So there are different types of the invasive infections we can use voriconazole. Positive response with cerebral fungal infection suggests that this drug also penetrates the infected brain. So voriconazole can be given when there is some brain involvement. Rashes, visual disturbance, QTC prolongation and acute reaction on IV injection are the significant adverse reactions. Posaconazole is more newer than the voriconazole, newer ones. They have fourfold greater activity in vitro against the yeast and filamentous fungi, including the agents of the mucormycosis. So mucormycosis is also very serious invasive fungal infections where the posaconazole is very much effective. They have very long pH, 25 to 31 hours, large volume of distribution, extensive binding to proteins, used for the treatment of the oropharyngeal candidiasis. It is mainly approved for prophylaxis against the invasive candidiasis, invasive aspergillosis in patients greater than 13 years of age who have prolonged neutropenia or severe graft-versus-host disease. That is, the patient is taking some cancer chemotherapy and there may be chance of fungal infection. the patient have taken some graft, some organ transplant, so there is chances of the graft versus host reaction. So in these cases, we have to use the posaconazole prophylactically also. Common adverse effects are nausea, vomiting, diarrhea, abdominal pain and headache. Local azoles means they can be given just locally, topically. Clotrimazole, Echinocandins and Miconazole, they mainly used in different types of the local infections. For example, tinea infections, different fungal infections in the skin, ringworm infection, athlete's foot, otomycosis, that is within the ear, fungal infection within the ear, oral, cutaneous and vaginal candidiasis. Mechanism of action is similar. Clotrimazole is mainly favored in vaginitis. Clotrimazole pessary is also there because of the long lasting residual effect and once daily dosing. So fungus, vaginitis, we can use the clotrimazole. Miconazole causes frequently vaginal irritation and pelvic cramp. That's why this is lesser used nowadays. And this can be available as lotion, cream, powder, vaginal tablets. All these are different formulations are available. Now next coming to the Griseofulvin. Griseofulvin comes under a group heterocyclic nitrofurans. Griseofulvin is the second antifungal drug that was invented after the Amphotericin B, but due to some adverse effect as well as the lesser activity, it is lesser used nowadays. It is useful for superficial fungus infections by dermatophytes derived from the Penicillium griseofulvum. They have no antibacterial activity. They are effective against most dermatophytes but not against the Candida. Dermatophytes mainly actively concentrated accounts for selective toxicity against them. They are mainly taken up by newly formed keratin and deposited in keratin precursor cells, and when these cells differentiate, the drug is tightly bound to and persists in keratins. Because the long period of time it attaches with the keratin and remains within the skin so that the fungus infection will not be repeated. So as the fungus containing keratin is shed, it is replaced by normal tissue, providing prolonged resistance to the fungus invasion. So this happens due to the Griseofulvin. So this mainly interferes with mitosis, results in multinucleated and stunted hyphae. So hyphae is another part of the fungus. Already you have read in the mycology. So this hyphae becomes stunted and becomes multinucleated. So ultimately the fungus cells will not be developed. So this is the structure of the Griseofulvin. So in most fungi, these hyphae are the main mode of the vegetative growth. So vegetative growth of the fungus happens by means of this hyphae, and these hyphae, all the hyphae together, they are known as the mycelium. Yeast are unicellular fungi that do not grow as hyphae. That's why yeast are not affected by the Griseofulvin. So Griseofulvin acts within this, it goes within the nucleus, interferes with mitosis, and the hyphae becomes stunted and multinucleated. So abnormal metaphase configurations leading to failure of the daughter nuclei to fall apart and disorientation of the polymerized microtubules. So these are the ways by which it causes the stunted hyphae. It can be given orally and fats improve absorption. Usually it is taken after food. Absorption depends on the particle size. Duration of treatment depends upon which is affected. For example, 3 to 6 weeks for skin and hair, 3 to 6 months for nail. If there is fungus infection of nail, usually a long period of time treatment is needed, whatever may be the treatment. So onychomycosis, fungal infection of the nail, very common. Usually minimum 3 to 6 months treatment is needed, either with Griseofulvin or Terbinafine. We will come to this later. But for skin or hair infection, usually lesser, 3 to 6 weeks is needed. Treatment should continue till whole infected tissue is shed off, because it goes within the keratin and ultimately long lasting protection will be happen. So Griseofulvin is fungistatic in vitro for various species of the dermatophytes like Microsporum, Epidermophyton and Trichophyton. These three are the main three dermatophytes: Microsporum, Epidermophyton and Trichophyton. Used orally, 125 to 250 milligram tablets are available for the Griseofulvin. Adverse reaction: GIT abscess, CNS symptom, hepatotoxicity, leukopenia, photosensitivity can be happen. This is a microsomal enzyme inducer in comparison to the ketoconazole, which is an inhibitor. Causes decrease in activity of the anticoagulants, causes intolerance to alcohol, and phenobarbital reduces its oral absorption, so failure of therapy happens. So all these antifungal drugs, different antifungal drugs usually have very much drug-drug interactions. Flucytosine is again acts on the nucleus. It is a fluorinated pyrimidine related to the fluorouracil. They have restricted spectrum of activity, useful against the Cryptococcus neoformans, Candida and the agents of the chromoblastomycosis. they are orally absorbed, widely distributed even in the CSF. That's why it is very much effective against the Cryptococcus neoformans, which causes cryptococcosis. Excreted in urine, converted in fungal cell to 5-fluorocytosine, 5-FU. When you read about the anti-cancer chemotherapy, you see that the 5-FU is also an anti-cancer drug. So this ultimately converted to 5-FU, which is a cytotoxic to the fungal cells, and ultimately it dies because it's an anti-metabolite. So flucytosine is basically anti-metabolite. So this is the OS by which it mainly inhibits this. So all susceptible fungi are basically capable of deaminating this flucytosine to 5-fluorouracil. You can see this is the 5-FU, 5-fluorouracil. So flucytosine by means of the cytosine deaminase is converted to 5-fluorouracil. This 5-fluorouracil then is converted to 5-FUMP, and then by means of the UPRTS it is converted to different other intermediaries, and ultimately DUMP and DTMP are formed. And when it is blocked, these flucytosines, this DUMP and DMP, they are potent inhibitor of the thymidine synthetase. So these are the intermediary agents which are the inhibitor of the thymidine. The thymidine is a part of the DNA. Thymidine is a part of the nucleus that is needed for the fungus growth and development. So ultimately fungus development will be blocked because this flucytosine is converted to the 5-fluorouracil. This 5-fluorouracil is cytotoxic, and they ultimately causes inhibition of the thymidylate synthase and that of the DNA synthesis. The selective action is due to the lack of this cytosine deaminase in mammalian cells. So this cytosine deaminase is not present in our cells. That's why in normal cells, usually this flucytosine is not converted to the 5-fluorouracil. That's why the normal cells will not be affected. Only the fungal cells contains this enzyme cytosine deaminase. That's why they can convert this flucytosine to 5-fluorouracil, 5-FU, which is a cytotoxic to the fungus. Usually monotherapy is not given. It is usually given in combination with the Amphotericin B or the Fluconazole or the Voriconazole, usually used for the invasive candidiasis, cryptococcosis, aspergillosis. So these are the different drugs, different doses. This is not needed. Next, coming to the echinocandins. So echinocandins now act on the cell wall. So firstly, we have seen those drugs that act on the cell membrane, that is the polyenes and then the azoles. Then we have seen some drugs that act on the nucleus, that can block the mitosis, that can block the DNA synthesis, etc. Now coming to the echinocandins, they inhibit the formation of the 1,3-beta-D glucans in the fungal cell wall. So fungal cell wall contains 1,3-beta-D glucan. So this 1,3-beta-D glucan synthesis is blocked by the echinocandin group of antifungal drugs. There are 3 drugs: Caspofungin, Micafungin and Anidulafungin. Caspofungin, Micafungin, Anidulafungin, this comes under the group of the echinocandins that blocks the cell wall synthesis of the fungus cells by blocking the formation of the 1,3-beta-D glucan. Candida and Aspergillus species are usually blocked. So you can see this is the fungal cells, fungal cell wall. The strength of the fungal cell wall is mainly maintained by the fibrillar polysaccharides, largely this beta-1,3 glucan and the chitin, which bind covalently to one another. You can see this is the glucan, beta-1,3 glucan, these are the chitins, and these are the glucan synthase complex. Ultimately they covalently binds with each other so that gives the strength to the fungal cell wall. There are glucan synthase complex in the plasma membrane that synthesize this glucan synthase complex that synthesize the beta-1,3 glucan. Echinocandins mainly attaches with this glucan synthase complex, and ultimately there will be loss of the structural integrity of the cell because this beta-1,3 glucan will not be synthesized. Caspofungin, it is a water-soluble semi-synthetic lipopeptide. It is basically obtained from the Gladia lozensis, which is a ferment, which is also present in the environment. Approved for the initial therapy of the deeply invasive candidiasis and a salvage therapy for patients with invasive aspergillosis. Usually the echinocandins are given intravenously and they are used only in the invasive cases. Also approved for esophageal candidiasis, treatment of the persistently febrile neutropenic patients with suspected fungus infections. usually well tolerated. Micafungin and Anidulafungin more or less similar. Micafungin is mainly used in deeply invasive candidiasis, esophageal candidiasis, prophylaxis of deeply invasive candidiasis in hematopoietic stem cell transplant patients. Anidulafungin again is used in candidemia of non-neutropenic patients and for the treatment of the esophageal candidiasis. That is more or less similar. Just remember these are mainly used in invasive candida infections. Next, coming to the terbinafine. Now, terbinafine is very commonly used off and on. This belongs to the newer allylamine class of antifungals. It can be given both orally and locally. Lipophilic, widely distributed. This is a fungicidal drugs in comparison to the azole antifungal drugs, which are mainly fungistatic. They possess acts by non-competitive inhibition of the squalene epoxidase. Already we have seen the ergosterol synthesis pathway. So this is the same thing. Already we have seen the ergosterol synthesis pathway. From the acetyl-CoA ergosterol synthesis, terbinafine mainly blocks this squalene epoxidase in the pathway of the synthesis of the ergosterol. And already we have seen what the Azoles act. Azoles act, they block the conversion of the lanosterol to ergosterol. So Azoles act here, they blocks the conversion of the lanosterol to ergosterol, and the terbinafine, which is a allylamine, acts here. They block the squalene epoxidase so that the squalene cannot be converted to the lanosterol. That is, terbinafine acts upstream to the azole antifungal drug. So they are used for dermatophytes and candida. Well absorbed, bioavailability is decreased to 40% because of very high fast-pass metabolism. Again, high protein bound, drug accumulates in skin, nails and fat like that of the Griseofulvin, and the initial T-half is 12 hours but extends to 200 to 400 hours at steady state. You can see the initial half-life is only 12 hours, but since they are concentrated within the skin cells, the half-life becomes very high when we are using this for a long period of time, approximately 200 to 400 hours. And for example, for onychomycosis, we need for a long period of the time of the treatment, we can give the terbinafine. And terbinafine acts by non-competitive inhibition of the squalene epoxidase. Terbinafine acts by non-competitive inhibition of the squalene epoxidase, which is an enzyme that converts squalene to lanosterol in the pathway of the conversion of acetyl-CoA to the ergosterol. And this ergosterol is the main component of the fungal cell membrane. The same thing already you have seen. So there may be some gastrointestinal upset, hepatic dysfunction, rash, taste dysfunction, dryness, erythema, etc. can happen. But the important point is there is no interaction with cytochrome P450. Most of the antifungal drugs, be it Amphotericin B or azole antifungals or other drugs, there will be drug-drug interactions because they are mainly metabolized by the cytochrome P450 systems. But terbinafine, there will be no drug-drug interactions. Usually cream, tablets, all are available. For example, for the Taenia pedis, that is fungus infections in the foot. Usually 250 mg once daily for 2 to 6 weeks is needed. For onychomycosis, that is fungal infection in the nails, these are very common. You will see many patients in the OPD. So you need approximately 3 to 12 months of the terbinafine. So you can see for the onychomycosis for a long period of the time of treatment, usually 3 to 6 months is needed for the complete healing of the onychomycosis. And it is alternative to fluconazole. Already I have seen fluconazole can also be given for the onychomycosis, but some patients are resistant. This is not recommended in patients with marked azotemia, that is nitrogen level is high, or hepatic failure, because terbinafine plasma levels are increased by unpredictable amounts. So when the hepatic compromise is there, or we should not give this. Rifampicin decreases and cimetidine increases the plasma terbinafine concentrations to some extent. So after terbinafine, there are some topical antifungal drugs. Details is not required, just remember the names and some on which it acts. Topical means it can only be used by topically. For example, cyclopyroxolamine, very commonly used, previously very commonly used, now somewhat decreased. They are broad spectrum antifungal activity, fungicidal to Candida albicans, Flocculosum, Canis, Megaphytes, Rubrum, so different types of the dermatophytes. So they are mainly used in cutaneous candidiasis, Taenia corporis, Taenia cruris, Taenia pedis, Taenia versicolor. Also 8% nail liquor is available that can be used in onychomycosis. So cyclopyroxolamine, haloprogrin. Haloprogrin is fungicidal to various species of the Epidermophyton, Pityrosporum, Microsporum, Trichophyton and Candida. Again, it can be used, for example, mainly used in the Tinea pedis, for which the cure rate is approximately 80%. So, fungal infections under the food, apart from the terbinafine, we can use the haloperidol ointment. Tolnaftate. Tolnaftate is effective in treatment of the most cutaneous mycosis like rubrum, mentagramorrhoids, tonsudans, flocculosum, etc. Mainly, again, it is used. It can be used as a cream, gel, powder, aerosol powder, etc. in different types of the dermatophytic infections, that is fungal infections on the skin. Naphthepin again, it is used in topical treatment of the Tinea crudis and Tinea corporis, that is fungus infection in different intratriginous areas. This is known as the Tinea crudis. Tinea corporis, that is fungus infections in the body, where we can use the naphthepin ointment or naphthepin cream. Butanafine is again, it is a congener of the terbinafine, more or less similar, used in different types of the dermatophytosis. Undecylenic acid is primarily fungistatic, mainly used in the treatment of the various dermatomycosis, especially Tinea pedis. Apart from this, it is also approved for the treatment of the diaper rash, Tinea crudis and other minor dermatology conditions. So, undecylenic acid, benzoic acid and salicylic acid. So, there is one ointment that contains both of these two, benzoic acid and salicylic acid. This is known as the Whitfield's ointment. So, Whitfield's ointment, the content is the benzoic acid and salicylic acid. It combines the fungistatic action of the benzoate with the keratolytic action of the salicylate. Again, it is mainly used in case of the Tinea pedis, that is fungus infections under the foot. Because benzoic acid is only fungistatic, eradication of the infection occurs only after the infected stratum corneum is shed and continuous medication is required for several weeks to months. So, benzoic acid and salicylic acid combination known as the Whitfield's ointment, previously it was very commonly used mainly for the Tinea pedis. Tavaborole is the newest one, topical antifungal medication for the treatment of the onychomycosis, again the fungus infections in the nails. This is the first oxaborole antifungal agent approved by the FDA. So, this is a new drug in class, oxaborole antifungal known as the tavaborole. Tavaborole is mainly used in the onychomycosis. They mainly inhibits an essential fungal enzyme, leucyl tRNA synthesis. So, leucyl tRNA synthesis mainly used in the protein synthesis within the fungus cells. So, they are mainly blocking the protein synthesis within the fungus. The advantage that it can be used topically, so lesser chances of the systemic side effects, debridement of the affected toenails is not required, negligible inhibition of the cytochrome P450 enzyme, so at least chances of the drug-drug interactions. So, this is all about the antifungal drugs. So, just I am showing, these are the example of the topical antifungals: cyclopyroxolamine, haloperidol, tolnaftate, naphthepin, butanafine, undecylenic acid, benzoic acid and salicylic acid. And lastly, tavaborole is the newest oxaborole antifungal drugs. So, this is all about the antifungal drugs. Antifungal drug is very important. For example, the questions can come most commonly from the Amphotericin B. Amphotericin B, the short notes, different concerns, different formulations of the Amphotericin B. Amphotericin B, adverse effects, why the liposomal amphotericin B used, all these questions can come, all this comes under the amphotericin B. Next to amphotericin B is the azole antifungals. Short note can come with the ketoconazole, fluconazole, itraconazole or different types of the azoles. How the azoles mainly act, what are the fungus on which mainly azoles act, etc. Next, the third important is the terbinafine. Terbinafine short note, very commonly it can come, how the terbinafine acts, where the terbinafine can be used. Apart from this, there are some small questions can come with the Griseofulvin or Echinocandins. The short note can come with the Echinocandins, and some viva questions can come with the topical antifungal drugs.